Hello, everyone. Thank you for joining us. We'll give everybody a few minutes so they can log in and join. We are so excited that you're here for our Sickle Cell Disease Social Context and Advocacy, a patient and provider discussion live webinar provided by New York City Health and Hospitals Office of Quality and Safety. My name is Dr. Komal Chandra. I am an associate director on the Value and Patient Safety team here at New York City Health and Hospitals. And I have with me,
I'm Dr. Stasha O'Callahan. I'm an emergency room physician at Harlem Hospital and a clinical leadership fellow in the Office of Quality and Safety here at New York City Health and Hospitals.
We are so excited to provide this opportunity of a panel of physicians and patient advocates and to talk about sickle cell disease with the community. We're so excited for all of you that have joined us today. You can chat with us in the chat box, whether through YouTube or through our WebEx link. We'll start off by introducing our panelists. We're going to have some questions for our panelists today, and then we're going to share a pain protocol that has been launched in our system, as well as an advocacy tool for patients and their families. To start off, we're going to introduce the AVP of Value and Safety for New York City Health and Hospitals, Dr. Mona Kraus. We'll go to the next slide also so you can see everybody's names. Dr. Kraus.
Thank you, Komal. I just want to say thank you to everyone attending this webinar today for such an important topic that affects so many of our patients at New York City Health and Hospitals and beyond. We are so proud of all the innovative work being done in health and hospitals in advancing the care of our patients with sickle cell disease. Ensuring that our patients with sickle cell disease have optimal, individualized, person-centered care is certainly a priority for our system. So thank you to our moderators and our panelists for taking the time to make this webinar happen, and I'm sure we are all going to learn a lot today. So with that, I'll turn it back to Komal and Stasha. Thank you, everyone.
Thank you. So before we introduce our panelists, Dr. Callan, can you explain to us a little bit about why we're here and a little bit about sickle cell?
Yeah, just a very basic overview. Sickle cell disease is a group of inherited blood disorders where blood cells in patients who have sickle cell disease take a rigid sickle-like shape. And so patients can experience both anemia as well as severe pain crises and other complications due to this change in the way that the hemoglobin in the blood is formed. It's a federally designated disparities disease, and there are many diseases and places where there's healthcare disparities across our healthcare system, and where different diseases care is influenced by structural racism. And sickle cell disease it primarily affects patients of African and Mediterranean descent. And so there is a high risk for structural racism and healthcare disparities to affect the care of patients with sickle cell disease. We're here today to further education about this disease and about ways to mitigate the effects that structural racism and healthcare disparities have on the care of patients with sickle cell disease. And so with that, I'd like to introduce our panelists to get started and have this educational session.
So can you please share with us your name, the borough that you're from, which hospital you either work at or seek care, and your connection to sickle cell? We'll start off with Dr. Dave Holson.
Hi, good afternoon, everyone. My name is Dave Holson. I'm the Deputy Chief Medical Officer here at New York City Health and Hospital Queens, and I'm practicing emergency physician for over the last 2 decades, and a big advocate for the care of our patients with sickle cell disease.
Thank you so much. We'll move on to Mrs. Candice Delaire.
Hi, good afternoon. I'm Candice Delaire. I'm the founder of Candice's Sickle Cell Fund Incorporated. I have sickle cell disease SS type, and I'm in the Bronx, New York, and I received treatment at Lawrence in Bronxville.
All right, thank you so much. Now we'll move to Dr. Kenneth Rivlin.
Hi, my name is Ken Rivlin. I'm a practicing pediatric hematologist in Jacobi Medical Center in the Bronx. And my interest in sickle cell disease is really because of the tremendous disparity I've seen in treating cancer patients and sickle cell patients. And it just is an injustice that needs to be corrected. Thank you.
Thank you so much. And finally, Ms. Willen Chetram.
Hi, good afternoon, everyone. I'm Willen Chetram. I live in Queens, New York, and I receive care at Queens General Hospital. My connection is that I have sickle cell. I'm a patient.
Thank you so much. Thank you so much, Willen. All right, so we'll start off with our questions. So we'll go to the next slide. Sasha, do you want to begin?
Yes. Dr. Holston, we were hoping that you could give us some of the historical background of sickle cell disease.
So, as was alluded to earlier, sickle cell disease is an inherited disorder. But the key thing, it is a lifelong challenge for each patient. 1 in 365 newborn Black Americans will have sickle cell disease. 1 in 13 will carry the trait. And currently, around 100,000 Americans are living with sickle cell disease. 10% of these patients are in New York City, and the majority of them are being taken care of in our New York City health and hospital system. The other challenge is transition of care from pediatric to adult. And what we have seen is mortality actually increases during this transition period. For the age group 15 to 19, it's 0.6 per 100,000. And ages 20 to 24, it becomes 1.4 per 100,000. And we have seen mortality rates continue to steadily increase since 1979. So it's a real challenge. And what we have been doing at Queens in particular is really changing our approach to patients with sickle cell disease. And it came around from training of providers, education around implicit bias, and also addressing the medical mistrust that exists between patients and providers. And so with this, we have seen significant improvements in terms of utilization of ED resources, and even admissions have decreased tremendously among our patient population.
Thank you so much for giving us that background. Dr. Rivlin, could you follow up on that, please, with what are some of the major steps New York City Health and Hospitals is taking to improve care for our patients with sickle cell disease?
Yes, thank you. That was a great summary. We're doing at New York City Health and Hospitals is prioritizing sickle cell disease, really working to eliminate the disparities in the quality of care faced by people with sickle cell disease. Specifically, we're working to standardize our care across all our institutions to provide the best of quality of care. We're trying to increase the use of disease-modifying therapies. We're trying to improve the transition program between pediatrics and adult care. We're creating individualized treatment plans for people affected by sickle cell disease. We're working hard to decrease the stigma faced by individuals with sickle cell disease by creating educational programs and partnering with community-based organizations. And we want to provide our patients the opportunity to participate in clinical research. So we've established that. We're working at the national level to ensure that we are providing the best care we can. So we are working with HRSA, which is the Sickle Cell Treatment Project, as a national initiative, how we can demonstrate improvements for sickle cell disease. We're working with the Office of Minority Health to increase the use of hydroxyurea. We're working with the American Society of Hematology to be able to offer our patients the ability to participate in clinical trials, and also as a learning collaborative, how do we best provide care for people with sickle cell disease? And we also became a part of the National Alliance of Sickle Cell Centers so that we are providing essentially best care that we have evidence for. Thank you.
Amazing. Thank you so much.
So, Ms. Chetram, we were hoping that you could tell us a little bit about your experiences with healthcare providers. You said you get your care at Queen's Hospital, and we would like to know a little bit about what that's been like and about your experience.
Okay, my experience is that it can become a long, painful wait sometimes when the providers who are on shift is not familiar with your backstory, right? Because there is a stigma that is widely associated with sickle cell patients. I want to say that the truth is myself and others only go to the hospital when the prescribed pain meds that they would have been given are finished, or if it's not just a common flare-up, but it's actually like a full-blown crisis, right? These pain levels can escalate further when I am at the hospital on a bed in the ER without treatment for a delayed duration. All right. That's just sometimes that I would experience that. I'm not saying that that's the case every time, but I want you to know. My experience is that prolonged painful crisis without treatment causes me to second guess my decision to go to ER for treatment. All right. As against going to another hospital. Also, when providers delay or withhold my pain meds, it leaves me feeling very frustrated. And again, these are just on some occasions. Thank you.
Thank you for sharing that experience, especially about being in the emergency department when you're having a pain crisis. Could you talk a little bit, and then we'll move on to Mrs. Dallaire, about any specific people or programs that have positively impacted you during your care at Queen's Hospital? Ms. Chetram?
Yeah, the sickle cell support group, been very helpful, and the provider, Dr. Arturo, has been very, very helpful in making my stay there as a patient more successful.
Amazing. We're going to ask you to elaborate on that at some point, so keep that in mind. Thank you so much. We'll move to Mrs. Dallaire. Can you please tell us about what is it like to have a pain crisis, either for those that are not familiar with sickle cell disease or may not know somebody that's impacted by this disease, but can you tell us about what it's like to have a pain crisis, but also what is it like to go to the emergency room in pain? You know, what could make the experience better or the experience worse for you, either in your experience or based on the experiences of others that you know?
So a crisis is described by many as being stabbed multiple times. Even though we may not know what that feels like, we can all imagine that it can be pretty uncomfortable. A pain crisis can come in many forms. It can be mild, moderate, or severe, sharp, or achy. And when I enter the emergency department, I usually have tried medication at home and I am at wit's end. So I can't do anything more for myself. When I go into the hospital, I am hoping to get the pain medication of my choice. And sometimes I discover a champion in the emergency department that respects me knowing my own body and what works for me. And I usually get the pain medication along with IV and Benadryl and oxygen when needed. An experience that is not desired is usually long wait times and just being discouraged that I'm not being trusted. So, sharp pain for me and severe pain causes me to pace back and forth. And before I go to the emergency room, just try to gather my things and get out. And a lot of times I'm crying, and the crying is not so much because of the pain, but it's because I'm afraid of what my experience is going to be like. I'm afraid it's going to be delayed. I am a person that knows so well that if I'm treated immediately, that I can probably exit the emergency room and not be admitted. And if I'm not seen right away or just not given the meds that I need right away for my terrible pain, then I'm going to be admitted. And I feel like these things can be prevented if we're just trusted. There's more trust. And I love the idea that the individualized pain plan will take place at the H&H hospitals, because that just will save so much time. Thank you.
Thank you so much for giving us that experience from your own perspective. I really felt like I could imagine how it feels to be waiting, or you're not sure if you'll be seen or admitted, and how that might make you feel when you're already when you said that stabbing pain. I can only imagine what that might feel like. So thank you for explaining that to us.
Yeah. So you told us an amazing testimony of what it's like when you are having a pain crisis, but in your daily life, when you, like, as someone who has sickle cell disease, how would you say that your normal daily life is influenced by having it, even on days where, you might not be having a pain crisis?
We'll start with Wulan, if possible, and then we'll move to Candace again. Is that okay?
Yes. For me, it causes me to plan and structure my activities. It causes me to make calculated decisions that won't affect my body negatively.
Could you give us an example?
For instance, extreme weather condition can trigger crises. So I would want to make sure that I am not exposed to those extreme weather conditions, whether it's severely hot or extremely cold. Both can have adverse effects on someone with sickle cell disease.
Candace, would you like to share your thoughts?
Sure. Every day I think about, when I wake up, just if I'm in pain, trying to feel out my body. Am I going to have to take Motrin in the morning? I suffer from chronic pain in my lower back. Sometimes, like Wulan said, if it's cold, I have to take, pain meds, because even dressing in layers, sometimes a sickle cell crisis is unpredictable. A lot of times, it's just trying to figure out how to take care of ourselves, even with the drinking water and proper rest, like we're always told. Sometimes we still encounter pain crises. So it's really difficult to go day to day, simply because the disease is unpredictable. And one moment you can be feeling fine and the next minute not. So it's hard to plan. And planning is always a prayer that you don't get sick to disrupt your friends' exciting celebrations or your own or your children's. So it's very difficult to muster and to just figure out, daily how to handle it.
Thank you so much for explaining that. It seems like the words that came up a lot were unpredictability, but also trying to prepare for the unpredictability and the impact it has on your day-to-day functions and the people around you. And I'm curious, because this could be an invisible disease, and the fact that, or somebody may not know that you're going through a pain crisis, or you might be struggling in a certain day. Can either of you elaborate on how has this impacted perhaps your relationships or the people around you, or maybe even just explaining, hey, I'm not having a great day? Could you share a little bit about that?
For me, having someone like a spouse who is understandable means a lot, because then you have someone who knows and who trusts you and wouldn't second guess whether or not you actually need to go to the hospital, but will actually try to get you there as quickly as possible. So having that type of support system, whether it's a spouse or a family member, is very, very meaningful. Thank you.
It's really nice to know. Candace?
So this is a topic that's actually going to come up in the next support group that we have. We have a support group the first Tuesday of every month. And the topic is being happy and relationships, and just like, when do you disclose to someone that you have the illness? So for me, what I try to do is not say that I'm not feeling well, which is probably the wrong thing to do. Unless it seems like it's going to get out of hand, then I'm like, telling my husband, I don't feel good. But, just a minute ago, I didn't say I wasn't feeling good. So it's all about timing for me and deciding, okay, is this just like a mild pain crisis that's going to go away, or is it going to turn into something big? So a lot of times I try to hide the smaller pain, but it's hard to try to figure out still. I have 2 sons and I've been married for 17 years, and I still struggle with when to disclose and not disclose that I think that this is going to be a problem, that I'm not feeling well. So I usually only mention it if it's something that I really feel that I can't handle.
I understand, but that can be a lot to keep in also, right?
It's a lot.
You don't want to impact others.
Right.
Dr. Holson or Dr. Rivlin, do you have any comments to add, or feel free to jump in as well if you have any patient experiences or?
As I'm listening to them, every time I listen to a patient who is living with this dreaded disease, I learn something new as a physician. And, and kudos to Candace and Willan for being here and being brave to share their stories. And listening to both, I keep hearing this constant theme of just trust, and as physicians, when you have a patient who's having an asthma exacerbation, which they've suffered with since a childhood, and comes in and says, I don't feel well, I'm wheezing or whatever, we take them at their word, and I really think we need to do a better job to just listen and believe our patients when they're telling us about their pain, because they're living it, they're experiencing it. And that's how we're gonna overcome this mistrust or distrust and be able to work with our patients to get the optimal outcomes that I think all of us want as physicians. So thank you, ladies.
Beautiful. Beautiful point. You said listening can go a long way into healing and building trust with our community. I think that's a great takeaway we can all utilize. Dr. Rivlin, any thoughts about patient experiences that you've come across?
Yes, I wanted to just highlight the severity of pain with sickle cell disease. two panelists have been very gentle in describing how intense that pain is, but the pain is described as worse than the pain of childbirth. The pain is described as worse than the pain of a broken hip. These are gold standards for what people are suffering. And one of the things I see as both a hematologist and an oncologist is how when a patient with cancer comes in with severe pain, they are treated as compared to a patient with sickle cell disease coming in with pain. And it's just shocking, that disparity. And that's my 2 cents.
Thank you for elaborating that point. As I realized that what you're describing compared to what we just heard is much more severe or intense, and I appreciate you bringing those stories to life for us.
Dr. Holson.
I just wanted to highlight, a recent experience. I was covering the observation, and an older African-American woman, not new to our system, normally followed by a different hematologist, but required significant amount of pain medications. And what stuck with me was how apologetic this patient was, how almost as if she was trying to prove to me that I'm a decent person, I'm a good person, I'm so sorry that this had to happen. And and no matter how much I kept saying, don't worry, I got you, we'll take care of you, we'll give you what you need, she kept repeating this. And the only conclusion I could come to, this has been her life experience, that she has to constantly be proving and explaining who she is and hopefully to get the treatment that she deserves and needs, and with the dignity that she deserves and needs. And for me, that's one of these experiences that will probably stay with me for the rest of my career, that we really have to do something better in terms of how we approach these patients who are extremely vulnerable and coming to us at a time of need.
Thank you. Next question.
Yeah, I think we've done an amazing job of kind of setting the stage for what what this experience is like and what some of the issues are with both trust and, believing a patient is in pain, getting to treat pain in a timely fashion. These are some of the things that I was hearing and that I've experienced in the emergency room as well. And I was wondering, maybe both from the patient perspective and from the physician perspective, whoever would like to chime in, but maybe we'll start with Candace. What kind of things do you think that healthcare workers or hospitals can do to improve your care?
Well, I think the individualized pain plan is very important to getting to assist us immediately, especially because wait time is so long and sometimes there's nothing that can be done about the wait time. When we are seen in the hospital, at least the doctors can have a guide as to what this patient usually takes. And I think it's important to address the situation with everything that may be of assistance, like the oxygen in the IV, because I've been denied those things. And honestly, I feel like I need all of it, because if I already tried pain meds at home, then I'm feeling like I need the IV and the oxygen and IV push medicine in order to get rid of the pain. And I don't feel like I should be denied those things.
Thank you for giving us that experience from your perspective. Willan, do you have a similar experience, or what do you think there are some ways that healthcare workers or hospitals can do? What could they do to improve your care or the care of a patient with sickle cell disease?
I think that my care can be improved when healthcare workers receive updated training about addiction biases within the healthcare system. and also training with regards to stigmas associated with sickle cell disease and treatment that currently exists within the healthcare system.
I think that's super important. And I know there was, in 2021, the NIH even released kind of some findings that the number one thing that we should be doing to improve and reduce disparities for patients with sickle cell disease is more provider-facing education on stigma. And just like you pointed out, I think that's so important. And I thank you for highlighting that. Dr. Holston or Dr. Rivlin, are there any specific ways that you feel that you could improve your practice to provide better care to patients with sickle cell disease?
Well, I'm going to just speak general in terms of just emergency medicine. And because again, most of these patients, when they're in a severe painful crisis, will show up in an emergency department. And the National Heart, Lung, and Blood Institute actually did a survey to look at ED providers reporting awareness of actually treatment guidelines. And it was hitting at 32%. So that's telling me there's a gap. All right. And when they spoke to patients with sickle cell disease, 54% of them said they were not receiving their ED care quickly. So to me, those are two major areas we really need to focus on. And I'm glad we have come up with a standardized pain protocol in health and hospitals. And we ran it also through the Council of ED Directors to get buy-in as we look to have this becoming the standard across the board. Because I think having a framework of reference will also help physicians as they manage patients with painful crisis. The other thing, again, I'll emphasize is listen and believe. That's the only way we're gonna build trust, all right, as we take care of patients. Ms. Chetram alluded to it, but we have an NP here at Queens, and we've found that has been a great addition to the team because the NP knows the patients, one, two, is also their advocate and will follow these patients wherever they are, in the clinic, inpatient unit, observation unit, emergency department. So they have an advocate in this NP who knows them well and will see them wherever they are in the institution. So there are different models, but it definitely helps to have somebody who coordinates the care for these patients. I think personally, as physicians too, we have to be aware of our own implicit biases when caring for patients and choose to find the tools necessary so that we can start overcoming them. The other thing which for me is important is avoiding stigmatizing language in the medical record. All right, we all have heard the terms, the drug seeker, the sickler, the whatever it is, frequent flyer. We've all seen these terminologies, heard these terminologies being used. And I think we need to reframe that. For me now, it's a patient with sickle cell disease, all right, a patient living with sickle cell disease, whatever it is. But I think we need to reframe the context in which we approach this.
I think those are another amazing takeaway points is, practicing, I guess, more inclusive language, listening more, but also being aware, how are we talking about patients who may have sickle cell disease, not even saying a sickle cell patient, right? A patient who has this disease. And I love all of the, frameworks that you just provided that we can all implement in our work. Dr. Rivlin, we would love to hear from you as well about ways that you feel that practitioners can, provide better care for patients with sickle cell disease.
So one of the common themes that's coming across is believe the patient. That's foremost. These patients, when they're talking about pain, the pain is severe and they've lived with that pain for all their lives, so that they're not going to have heart rate rising, or when they're not going to have the same physiologic symptoms that people think about with pain. They can be holding a simple conversation with you with a severe pain. The other part is we need that voice of the patients. We need the voice of the sickle cell community-based organizations in the ED and in the clinics, so that they can give their voice and their opinion when they're not in pain, so that that bias can be driven away, because we see the patients through all aspects of their lives. As a hematologist, I see the patients when they're well, when they're doing pediatricians. So when they come and say what great job they did in school, or they just got accepted to this college, that same perspective needs to be done in people that only see the patients when they're in pain. So they need to see that whole person of the patient. So those are my quick thoughts on that. We need that continuous voice of the sickle cell community in all aspects of our care.
What a beautiful perspective of seeing a patient beyond their pain. I think that rings very true indeed.
Yeah.
Choosing Ted?
No, I just lost for words. I just feel like my big takeaway is just so much how once you humanize something and hear firsthand, and you really realize how important trust is, and believing the patient and getting to know someone for their whole self, and how that should be kind of paramount in the care that we're providing. That's what I'm left with.
Wonderful. It's a wonderful display of medical humanities in practice. So thank you, everybody, for sharing these beautiful tidbits with us. Willon, I'd like to ask you about support, and which areas do you receive support? How do you find, a group of people that helps you, feel heard, feel supported, have resources? What has that been like for you?
For me, thanks to God, I've grown up in a family who has been very supportive. I have emotional memories of my brothers lifting me from the house to the car and then to the ER. Brothers who were younger than me. What is big is that there is someone there at the hospital who knows me, just as was mentioned before, knows me while having a crisis and without having a crisis. So there's that level of understanding there. And so my NP, my nurse practitioner, Dr. Arturo, he has been very supportive while there at the hospital to receive care. Sometimes I just need to send him an email or call the office to let him know, okay, I'm in the ER, and he gets there to me, and he gets there to me. So that's very important. Thank you.
Thank you for sharing that. Candace, could you tell us a little bit about the group that you formed, or other support services or resources that you'd like to advocate to the group here?
Sure. So we established a support group about a year ago, and it was because patients expressed interest in having a safe place to share their experiences. So every first Tuesday of the month, we meet virtually. Patients educate one another, which I love, because patients know a lot, and they're able to help their fellow warriors. We call ourselves warriors. We usually have a guest speaker, and we discuss topics such as eye care, ED advocacy. We've been helping each other advocate in the emergency room, emergency department, And we talk about school certifications, transition to adult care, just to name a few topics.
That sounds wonderful. Thank you for sharing that information as well. And I think this is a good time for us to now transition to, we're going to share that pain protocol that's been mentioned a little bit in the webinar, and then also an advocacy tool. And there will be a link there for the support group that Candace was referring to, as well as another one. But at this time, if anybody has any questions for the panelists or the group, feel free to either put it in the chat or the Q&A function, and we can then start going through them. So why don't we go to the next slide? And Sasha, would you like to please share with us this pain protocol and give us some information about it?
Yeah, so this is the pain protocol that we developed here at New York City Health and Hospitals, and has been adopted for use in our emergency departments across our 11 acute sites. So this is a protocol that's meant to standardize care for when patients come into the emergency department with an uncomplicated sickle cell vaso-occlusive, or otherwise known as pain crisis. So we do have here the initial assessment, and then we have a kind of like red box indicating that you should pay attention for red flags such as fever, any trouble breathing, basically any signs of a specific sort of crisis or medical emergency apart from a more straightforward pain crisis that should be also addressed right away. And then if any of those red flags are addressed already or absent, then you move on, continue down the flow chart here. So we do have a goal that within 30 minutes of triage, a sickle cell pain crisis should be identified. So I know we heard a lot from our patients on the panel about, you know, how long wait times and not getting fast enough attention can be really poor for care. And so we wanted to, you know, call out that patients should be seen quickly. Then the next level of the protocol kind of indicates whether or not a patient has an individualized care plan, which we are trying to make kind of the gold standard across our system. So if the patient does have one filled out, then the provider in the emergency department is instructed to follow the individualized care plan, which will have, you know, the doses and medications that work best for that patient kind of already laid out. So it's definitely the best case scenario. But if not, then we do call for IV care right away, given that patients, if they're in the ER, probably already tried oral pain medications at home, with the mainstay being opioid treatments and a weight-based dose or based on the patient's home dose, along with IV hydration if the patient appears dehydrated, with adjuncts of NSAIDs like Toradol and Tylenol, as well as the opioids, which is all kind of following national best practice guidelines from the American Society of Hematology. We also advocate for drawing labs right away to kind of get a sense of how severe the crisis might be. Then the next steps involve reassessments rapidly within 30 minutes after each dose, checking to make sure no one is over-sedated, given that we are using pretty high doses of opioids in case a patient is not used to that. And then redosing with a higher dose if needed, if the first dose didn't work. And then redosing till a decision can be made whether or not it's safe for the patient to be discharged home, including advocating for discharging them home with doses of opioids until they can get their next appointment with someone to continue their care. And then if the patient doesn't feel comfortable going home, has required a lot of IV pain meds, had abnormal laboratory values, then we advocate for admission to inpatient or an observation stay at hospitals where that is what the protocol says to do. So that's kind of the protocol that we have developed here. And we have also luckily built it into our electronic health record as well. So that it's on the quick list for any ED providers that we have from Health and Hospitals on the webinar. You can access it on the quick list under the panels and protocols tab. It says sickle cell pain protocol, and you can open this PDF as well as go through a guided, pretty easy to use quick list of the pain medications themselves. So that's the protocol I'd like to share.
Thank you so much. A lot of that, I'm not going to lie, went a little over my head, being non-clinical myself. But what I took away from it was that what Dr. Rivlin and Dr. Holston talked about, having something that's standardized that we can follow. Patients knowing that this is existing, our staff being able to follow a standardized set of, this is how we're going to, respond to a patient who's coming in with a pain, crisis. And I believe that's also going to assist with the equity lens as well, of making sure that we're listening to and seeing the patient beyond their pain and responding to what they're feeling. So thank you so much for going through that. And of course, if anybody has questions, you're more than welcome to follow up with Sasha or myself at any time. Can we go to the next slide, please? For this presentation, for this webinar, we developed an advocacy tool. So this is tips for a successful ED visit for patients with sickle cell disease. We tried to interview patients about, can you please help somebody that might not know how to advocate for themselves, especially if they're having a pain crisis and they go to the emergency department? What are some things that they can keep in mind? And I'm listening to Dr. Holston's story of that patient who kept feeling almost like a burden, or I'm so sorry, or I don't want to over ask. And I think we were able to summarize it to 3 main points, which is 1, to share your story and details of your pain early, knowing what is your pain like on a usual day? How is it different than usual today? What have you already tried taking at home medication wise? When did you take it last? What dosage? So knowing that or having it written out may be helpful. But also knowing tools for pain control. So if you have an individualized pain plan, discuss it with the ED. But if not, maybe you want to talk about creating one with your, providing team as well. But now you also know that there is that pain protocol that you can refer to as well. But lastly, it is okay and you should advocate for yourself and speak up. Especially if your needs aren't being met, or if you need assistance, or your pain is not being controlled. Communicating with either the attending physician or the charge nurse at that time. You can also reach out to patient representatives from patient experience, and you can also talk to a physician that you already have a good relationship with, if you're able to do so at that time. We mentioned some of the websites. So below there are 3 QR codes. One is our New York City Health and Hospital Sickle Cell Disease landing page. The second is the Sickle Cell Disease Association of America Incorporated. And third, Candace had talked about her website. This is Candace's Sickle Cell Fund, and I believe there's information about the support group on that website. Is that correct, Candace?
It is. And I didn't get to touch on some of the services that we offer. So can I go?
Would you like to do that now?
Quickly, sure.
Absolutely.
So patients referred to Candace's Sickle Cell Fund have an opportunity to meet with someone who can do some wellness check-ins, just to discuss, daily life with sickle cell disease. We also provide Uber Eats for those that have been in the hospital for a week or more. They can also participate with that program. We have giveaways during the holidays. So we give like heating blankets, and we provide trips to Great Adventure in the summertime to children with sickle cell disease. And we have a spa day, which during the COVID, actually, we turned it into just like a massage for patients individually to go and get pampered for the day. And a few other things we do, but we really try to provide services for patients that they may not get anywhere else. And I would love for Willan to reach out and possibly, take advantage of some of what we do. Arturo is awesome at Queens Hospital. Quickly, I had a patient reach out to me, and he contacted them within the end of that day for them to figure out services at Queens Hospital. So I think this is great for us to all come together and advocate. And we also provide scholarships for those that are going into college, and money for trade school. So please take advantage of our services.
Thank you so much for giving us an insight about all the amazing things you're doing to support the sickle cell community. And you had also mentioned Arturo. His name was mentioned a few times, and we're very thankful for the impact he's had on patients in the community. And so on the bottom right of the screen, there's also a sickle cell Zoom support group, which is the last Wednesday of each month from 1:30 to 4 p.m. You can contact Arturo, the nurse practitioner, directly. There's the number and email address there as well. But I mean, these are two support groups. These are two websites and resources that, I hope we can all, if you can take a screenshot of this and share it with others. I think that really does the important thing of providing resources to the community.
And reach out to us also after this if you work at one of our facilities or something and want a copy of this to disseminate to patients. Feel free. We can send you the PDF.
Wonderful. And information about these support groups was dropped in the chat as well. We're going to move to the next slide. And here, if you have a moment as we're starting to close up, we would appreciate if you can use this QR code to fill out a brief SurveyMonkey evaluation about this event, but also there are other events that you might like to see. Once again, if you have questions, feel free to put them in the chat and we'll start going through the Q&A. Do you want to read the first question?
Sure. So the first question from our audience is, how have you learned to advocate for yourself when interacting with the medical system? And how can I best advocate for myself? Anyone?
So I've learned how to advocate for myself really by teaching others how to advocate. And I know that there was a fellow patient that reached out to me and said, hey, I'm in the emergency room, and to no avail, they're not meeting with me and prescribing me medication. Can you call? And so I did, and a few people called, and the patient stated that they were seen. So sometimes it takes a friend or a caregiver to make a phone call in order to state that the patient is not being seen. I know administrative on duty is another option. If you contact them and state that you're not being seen or have a problem, you can reach out to them. And then I look for that champion that's in the room, because there is usually someone in the emergency department that is that person that you can go to and say, hey, please help me. So that's been, pretty helpful as well, to try to find that person, that supportive person.
Thank you. Ms. Chetram, do you have any tips to also answer this question? How can either a patient or a patient's loved one advocate for themselves when interacting with the medical system? Any advice?
Yes, thank you. Frequent trips to the ER has taught me that the medical system is a calculated, systemic, professional environment. And it's important that I advocate for myself. All right. Some tips that I can share for patients to advocate for themselves. Firstly, being prepared to retell your story over and over and over again to the receptionist, to the triage nurse, to the ER doctor or doctors. And when retelling your story, be specific and include all details. All right. I would say do not go to the hospital to seek treatment alone. Go with a family member or a friend who knows your basic medical history. Also, you must know your problem, your medical problem. Know what triggers your trips to the ER, what triggers your crisis. Importantly, what trigger the current painful crisis that you're facing. All right, and maybe make a note of any questions or concern that you have for the provider or the doctor who you will be seeing as it relates to your sickness. In terms of family members, they can advocate for loved ones by retelling the story and by being a good source of character reference. This is important because patients with sickle cell who are on an hospital bed, their voices and their cries are actually stifled by the prejudgments and biases that exist within the medical profession. Finally, I think doctors can advocate for sickle cell patients if only they can imagine the experience of pain that is felt when cells become sickle and thus preventing blood flow. Doctors can also advocate for sickle cell patients by showing empathy, demonstrating compassion, and demonstrating basic care for fellow humans. Thank you.
What a beautiful, beautiful statement, Milan. Thank you so much for being so comprehensive from what the patient can do, their family members, and as well as our medical teams. I really appreciate you giving that thorough response. Dr. Rivlin, briefly, if you have any, seeing it from the perspective of a practitioner, any advice for advocacy?
Trying to advocate for before the crisis happens, to have your game plan set up beforehand, to be able to go to a place that knows you, to go to a place that is compassionate, helps. It's hard to advocate in a busy day. It's hard to advocate during that crisis. It's better to have a center, a medical home that you know and that you can deal with, and that you know the staff that can advocate for you.
So being prepared or thinking about these things before you're in that crisis, if possible, is helpful. Mm-hmm. What a great point. Dr. Holson, anything to add?
I always throw in there the charge nurses. The charge nurses are usually there in the ED as the advocates for the patients. So it's always a good person to partner with to get care delivered to your bedside.
Definitely. Thank you. We have just one other question from the chat I wanted to address quickly, which is from one of our physicians. Is there a plan to extend the pain management protocol into the inpatient medicine programs? And I would say that it is definitely on our to-do list to make a standardized pain protocol as well for, now that we have one for the ER, for the inpatient units. It is definitely something that our office, and I know some of the other folks who work on sickle cell disease across the system, are interested in doing. And so if there's any interest from anyone in helping with that, feel free to reach out. But it is something that we know is needed. I don't know if anyone has any insight, Dr. Holson or anyone.
No, you have to. When we tackled this at Queens, we did it straight through from ED to discharge if patients got admitted. So definitely that's the next phase.
Great.
Great. One of the questions in the Q&A that I think was answered, Ray, I do want to address it, talked about what other platforms, programs exist at local facilities for support groups. And I just wanted to share that all the things that were mentioned between, being familiar and creating relationships with your medical teams, as well as both the support groups at Queens, as well as Candace's website, are all resources that anyone can utilize, but they were all partnered intentionally and co-designed with both patients and providers in mind. Mm-hmm. At this point, I think we're going to wrap up. And if you did not get a chance, please fill out that survey for us. We really appreciate the feedback. And if you have ideas for other events you might like to see, but we really want to thank our patient advocates that are on the call with us today, Mrs. Dallaire and Ms. Chetram, your insight, your perspective, and it's so powerful to hear your voice and the voices of so many others that you are representing today. So thank you for that, and thank you so much, Dr. Rivlin and Dr. Holson, for the work that you do, your perspective, and sharing all this information with us today.
Thank you all so much.
Thank you.
Thanks to our audience for your participation and for taking time out of your busy days to listen to a discussion about this really important topic. So I hope everyone learned something and, can be more successful going forward. So thank you.
Thank you again. Have a great day.